next lecture, red cells, and then we're going to do urobilinogen and bilirubin. That's kind of all in one. They kind of all overlap, and we'll talk about why. Hematuria, hemoglobinuria, and myoglobinuria. So, clinical significance, when we're looking at this, red cells in the urine is hematuria, red cells in the urine. Hemoglobinuria is hemoglobin in the urine. We talked about that in one of the earlier lectures, clear versus cloudy, red full cells versus hemoglobin. So hematuria we can get with any sort of bleeding anywhere in the urinary tract. Okay, if there's bleeding anywhere in the urinary tract, we're likely to have cells actually in the urine. There's some things we'll talk about why they may not be there, what's going on. Renal disease or dysfunction, so glomerular damage. The colander, the holes get so big that red cells start squeezing through. Interstitial nephritis, issues with the nephrons. Infections of the kidneys, infections of the bladder can cause red cells. Tumors, lesions, stone formation. We'll do a bunch on stone formation a little bit later, and you'll see why. It's crazy. It's like makes me cringe. What else? Generalized bleeding disorders, anticoagulant use. So people who have issues with their vessels, things bleeding in, things like that. Amount and severity do not necessarily correlate. So if there's a lot of blood, it may not be real serious. It might just be like where it's at, what's happening. If there's not a lot of blood, it could be very serious. So they do not always correlate linearly. In females, it can be a poorly collected specimen. If the female is having her menstrual time, you're going to get blood in the urine a lot of times, because remember I told you it takes 5 hands to get that clean catch. Did you guys read it? You see what I'm talking about if you really read through? So, a contamination, menstrual contamination sometimes, is that serious? No. So we could possibly have a lot of blood in the urine just due to contamination. So not correlated. Some diseases and things we're going to look at. Physical characteristics. Oh, yes?
Just a quick question. Is it possible to differentiate contamination from like menstrual blood from other?
Nope, blood is blood. So unfortunately, there's no way to do that. So if somebody's in the lab, we're going to report it out, and we need the doctors to know what's going on. So physical characteristics, color and clarity, specific gravity. Color, red. If it's clear, you're looking at hemoglobin. If it's cloudy, you're looking at red cells. Specific gravity isn't really going to be affected. We're going to look at it. Specific gravity could affect what happens to those cells, though, in the cups, and we'll get to that. The reagent strip, we're going to see positive for blood, if it's there. Hematuria, hemoglobinuria, myoglobinuria. We can't necessarily tell from the blood pad alone on the strip what's going on. pH and protein can also be affected. And then urine sediment, when we look microscopically, we can see cast white cells and crystals, sometimes in a freshly voided urine. So these are all different things that can correlate with what else is going on with the blood, and we'll break it down. Specific gravity affecting the red cells. So things like isotonic urine, intact red cells. ISO 1.010, that's where red cells kind of hang out, right? It's the same as glomerular filtrate. Red cells like plasma, it likes glomerular filtrate, it's going to be fine. However, if you get hypotonic urine, less than 1.010, you're going to end up having swollen cells. So they're going to end up like filling with water or fluid, and they're going to end up bursting. Sometimes they'll have ghost cells, which means you see just the outlines of the cells and not the full cell itself. Sometimes they're really, really big. Hypertonic urine, if it's a high greater than 1.015, 1.010 all the way up, the urine ends up becoming shriveled and spicule, or the cells become shriveled and spiculed. It's kind of like when you leave like a dodgeball in the backyard over winter, you know how it kind of like collapses down on itself? Kind of the same idea. In a hypertonic urine, the cell is going to kind of collapse down on itself. Sometimes with the little spicules, when you're looking at this unstained urine, sometimes people confuse it with a white cell, because the white cells have granules, but they're going to be quite a bit smaller, but they do get confused sometimes. So this is a normal cell and a normal isothenuric. Looks good, right? It's what's floating around your plasma. That's the same concentration of your plasma. Then here you get something a little bit lower, 1.007. It gets nice and big and swollen, and at 1.03 it's going to bust. And it's going to drop out the hemoglobin, and you're going to have it, all the color goes outside of the cell, and you're going to have the hemoglobin on the outside. Hematuria, we already talked about it. Red cells in the urine. Hemoglobinuria, free hemoglobin in the urine, yeah. Occult blood. blood not visible by the naked eye. Now, when we think of occult blood, you think of your hemocults, right? But it doesn't always have to be the hemoccult. It can be any blood not visible to the naked eye. So there are some of these urines you're going to get that look nice and yellow, and you're going to see blood in them based on the test strip result. That's occult. It's just not visible. And then myoglobin, free myoglobin, and it's from muscle breakdown in the urine. So we're going to break those all down a little bit too. Hematuria, we're going to see, when we see urine appearance, this is going to be like the red cells. So it's kind of cloudy here. This one you can kind of see it's broken down. It's clearer and it's darker. So hazy to smoky to cloudy, pink to red. The darker it is, nice it's the fresher it is, and our alkaline urine can make it darker. When we start seeing the amber, the brown, the black, it's older urine. It's had time to decompose and disintegrate. Think of like, blood clots, blood, when you get blood on your clothes, as it sits, it gets darker and darker. It's kind of the same idea. As the blood in the urine sits, it just gets darker and darker. So clinical significance. As I said, hematuria, bleeding somewhere in the kidney, somewhere in the system. Glomerulonephritis, interstitial nephritis, pyelonephritis, kidney or bladder stones, cystitis, urethritis, tumors, any sort of bleeding disorders, menstrual contamination, strenuous exercise, or like a blow to the back. Remember we talked about like football players and hockey players who have those pads now? Yeah, they never used to. Now they have them, and that's why we want to prevent that blow. We want to prevent kidney damage. Any of these things can cause bleeding anywhere in the kidney. So just because they're blood, now we have to figure out why, right? There's a lot going on. And of course, we don't have to do that. Then the doctor has to take them on for more testing. Clues of hematuria. Some of the dipsticks are microscopic. After centrifugation, we're going to see a little red button at the bottom. When we get to that point, we have these little conical tubes, and we're going to spin it down, and there's going to be a little red button at the bottom of the red cells. If there's a lot of blood, it's going to be a big red button. Then we have other issues that we'll talk about when we get to microscopics. The reagent strip should be positive. Reagent strips pick up a small amount of blood. It does not require a lot of blood for the reagent strips to pick it up. So when we go to dip it, when we're looking for any color, we're going to see either speckles or a solid pad. And we'll talk about that in the next, one of the next couple slides. If the reagent strip is not positive, but we think it's got blood or we see blood, we got to figure out what's going on, what's happening with our strips. So the strip's bad, sensitivity, specific gravity could be affecting it. Lots of things could be affecting it. Urine condition impacting the intact cells. As the urine ages and becomes more alkaline, red cells become less stable. That means they're going to start busting open over time. So we may not see red cells in the sediment, but we might have hemoglobin on the dipsticks. Dilute alkaline urine is going to cause those explosions. If it's dilute, they're going to explode. We're going to see the ghost cells. So you just see the outlines. You'll see plenty of those when we get to microscopics. Concentrated acid urine, the red cells don't tend to lyse. They tend to be whole. You tend to see more red cells in the acidic, more concentrated urines. If they're more concentrated, remember they shrivel up, so they're less likely to explode. Even then, though, you're likely to have a false negative or less numbers, because when these cells hit the pad, they have to explode. When they hit the pad, that's what gives you the speckles on the pad. And if they're crenated and they hit the pad, they kind of bounce off. Think about a water balloon. If I'm taking a water balloon and I really want it to explode, I want it to be nice and full, right? If I just put a couple tablespoons in a water balloon, we can throw that thing on the ground all day and it's never going to explode. Kind of the same idea. If they're sprinkled down and small, they're not necessarily going to hit the pad and explode. Hemoglobinuria. True hemoglobinuria is really rare. True hemoglobinuria, we're looking at in vivo hemolysis. Something is going on in the body to create hemolysis. When we get to blood bank, we'll talk about hemolytic anemia. And have you guys talked about hemolytic anemia yet in heme? Okay. I never know where things fall in heme. So things are lysing in the bloodstream and that hemoglobin is going through. So that's true hemoglobinuria, is when we see that. That is never good, right? I mean, I can't think of any good time to have hemoglobinuria. So what else? In vivo, in the body, in vitro, in the tube. Reactions occurring in the urine cup. So like I said, we end up having an alkaline urine, hyposthenuric urine, you're going to end up seeing in vitro hemolysis. I almost said vivo. In vitro, in the cup. Hemoglobinuria, it's nice and clear. Colors dependent on the concentration, right? If there's a lot of blood, it's going to be pinker, redder. If there's only a little bit, it might be yellow. We might not see any. Intravascular hemolysis, like I said before, so what happens, the red cells are hemolyzing in the bloodstream. The haptoglobin is going to bind to the hemoglobin, take it to the liver where it's turned to bilirubin. We'll have the next piece of the PowerPoint, we're going to talk more about the bilirubin. But yeah, this is kind of like the whole system of what's going on to create the hemoglobinuria. So what causes the hemolysis in the bloodstream? It can be a couple different things. We can get chemical and cellular destruction, transfusion reactions for the blood bank. When we get to blood bank, I'll get really into a lot of detail about how that happens and what's going on. But what's happening is you have antigen-antibody reactions. Antigen-antibody reactions that are ruining the red cells. They're destroying the red cells in vivo, in the body. I can't see which way it goes in. I still can't see. There it is. I told you guys my hands don't work well. Not just urine I throw at you guys. Bacterial toxins, certain types of malaria. If you have a severe bacterial infection, for example, E. coli, releases toxins in the bloodstream and it's going to cause hemolysis. Certain malarias are going to cause hemolysis. Venoms and poisons, spiders, different types of snakes, scorpions, all those things that we don't tend to have as many of in Wisconsin because of the cold, can cause intravascular hemolysis. Physical destruction, things that can cause it, these fibrin strands. So when you get this clotting that starts happening, sometimes these strands form and the red cells literally like break as they fall apart across them, right? It just slices them. Severe burns. It's patients that come into the hospital with severe burns on parts of their body that can cause hemolysis issues. Strenuous exercise, March hemoglobinuria from like marching military, they used to have it with strenuous exercise. That can sometimes cause it. So those are physical destruction of the red cells in the body. Myoglobin. Myoglobin is the breakdown product of muscles. When muscles break down, it has iron, so it acts like hemoglobin in the striated and heart muscle. And so when you do like these intense workouts and have myoglobin breakdowns, we have problems. Rhabdomyolysis is the name of like rapid muscle breakdown. Crushing injuries can cause it. There have been case studies out there about certain CrossFit used to have them. They've gotten better because now they have exercise physiologists coming up with the exercise. But like if I went in and just decided what exercise we were doing, you can actually overwork certain muscle groups and cause rhabdomyolysis, which can cause kidney failure. So there's actually some really interesting exercise myoglobin articles out there about this. Myoglobin is clear. The colors are anything from red to brown, so fresh or alkaline or old or acidic, just like we see with hemoglobin. Myoglobinuria can cause a positive on the dipstick. Things that we might worry about with being myoglobin, myocardial infarctions, heart attacks can cause muscle breakdown of the heart. You're going to see the myoglobin. Degenerative muscle disease like muscular dystrophy, these long-term muscle diseases where they're muscle wasting. Trauma, crushing injuries are notorious for causing myoglobin. Myoglobin is toxic to the kidneys. That's why we kind of worry about these types of things. The non-traumatic disorders, alcohol overdose, toxic ingestion, and heroin overdoses all can cause muscle breakdown and myoglobin release. So differentiating between them, it's going to be sometimes a little difficult because if you're looking at red cells, if there's only a few, it's going to be speckled. However, if there's a lot, the whole pad will be dark. So you're not going to be able to differentiate until you look at the microscope. If it's hemoglobin, it's going to be nice and smooth for a small amount. Myoglobin, nice and smooth. Red cells in sediment, red cells, we're going to see them. If it's only hemoglobin, it's going to be absent. Myoglobin, we're not going to see them. Urine appearance, cloudy for the red cells, clear and clear for the myoglobin. So you see these two are pretty similar. It's really hard. You're not going to be able to differentiate on the stick what we're looking for. So then we go into the blood tests. Do not worry about the blood tests now. You will get those in chemistry with Bao next semester. But there are other tests that we're going to do to differentiate between the hemoglobin and myoglobin mostly. Okay? Uh-oh, I broke it.
Oh. Is the battery okay with it?
Yeah.
Yeah.
It's getting old. My pointer's not even working very well anymore.
The front button's been used a lot more than the back buttons.
Yeah.
Oh, yeah.
I'll splurge and buy a new one. I think we might have one over in the drawer. I'll look when I'm done. So, the reagent strip for blood, what we're looking for, the principle is a peroxidase. Where else have you heard about a peroxidase principle? Basic lab skills. Might have been, bless you, might have been phlebotomy. The hemocults? Did you guys do those in BLS and phlebotomy, or phlebotomy, the hemocults? Did they pull those? I knew they were talking about it. Maybe they pulled it. I haven't taught it for a while. Okay. So what we're looking for is blood. So the hemocult looks for stool. It's the little cards.
Oh.
Did you guys do those? Okay. That's the peroxidase is the reaction.
I did that in microbiome.
Yeah.
Oh, microbiology, you guys did it? They pull some fun stuff in their micro course here. So peroxidase is what we're looking for, the activity of, we're looking for activity of the heme protein hemoglobin. So here is what's going on. The HO2 reduces chromogen with the red cells and oxidizes the chromogen, which forms like a greenish color. So if you remember from that pad, which you probably don't because you've only done 2 labs now, but it kind of starts as yellow and you're looking for the green speckles or the green pad, and that's what we're looking for that. So it's a peroxidase reaction.
I've done it, and it looks more blue than green.
That's for the hemocult.
Yeah.
For the pads and the urine, it's green.
Oh, okay.
It's a slightly different yeah. The chromogen, the coloring is slightly different. So we're looking at green on the strips. You're right, it's blue on the hemocults, but it's a peroxidase reaction. We're looking for the peroxidase activity of the red cells. So sensitivity, equally sensitive to hemoglobin and myoglobin. So again, we can't really tell the difference when we're looking at it in urine. It's less sensitive to the intact cells because, like I said, the cells have to hit it and explode. And if you got a nice red cell that's not blown up, so isosynthuric or hypersynthuric, where it's crinkled down, when it hits, it may not explode. So that's sometimes you might see them in the sediment, but the test strip was negative. That's one of the reasons why it could be. False positives, strong oxidizers. That's going to be a common cause of your false positives. Just like I said, when you're looking at false negatives, a lot of times you're looking for the ascorbic acid. When you're looking at false positive, think of your oxidizers. Okay, if you don't know, when in doubt, it's a good guess. Microbial peroxidase activity. So if we have a lot of bacteria, sometimes you can get a false reaction due to the amount of bacteria. And then menstrual contamination. I hate that we call that a false positive because it's not a false positive, it's contamination. But on boards and out in the real world, they still consider it a false positive because it's not disease caused, it's contamination. Okay? False negatives, there's that ascorbic acid again. We're gonna keep seeing it. Poorly mixed urine. Remember I taught you to always mix it? Because if it sits for too long and I go to dip and there are no red cells floating around in the urine, it's gonna look negative. So it's really important to always give it that nice swirl. Not only to look for foam, but to mix things up into it, whatever we're looking for. Elevated specific gravity could cause problems. Because again, if it's super high specific gravity, they're crunched down and they may not explode when you hit it. So you're gonna have false negatives or false reduced numbers. Formalin as a preservative. We're not going to worry about preservatives. Just always know preservatives are going to cause problems. Do not memorize formalin as a problem. Large amounts of nitrites can also cause an issue when you're looking at this. So if your nitrites are really, really high, you could possibly have a false negative blood. Microscopic is our confirmatory test for blood. We're going to spin it down and look at the sediment, see if we see red cells. So you can see here, we got different types of red cells all the way through. If the reagent strip is negative, but either appearance of the specimen and the presence of red cells in the microscopic, then we're going to test for ascorbic acid. We don't tend to test for the ascorbic acid, but we kind of know it's there a lot of times. In 1991, a study said 22.8% of all urines tested were positive for ascorbic acid. A lot of people take vitamin C on a regular basis, and as I said, we go through these, during COVID, at one point we saw this big surge because there was the study out that said, oh, vitamin C is good, so people started pounding the vitamin C. So we had a high, so we see this cycle up and down pretty regularly. Okay. There's your objectives and more objectives, key terms. We're going to hop into bilirubin and urobilinogen. So, hemoglobin catabolism. So, in hematology, you've talked about the breakdown of red cells, right? I love teaching this second semester because I used to be the first person to teach you all these things and it was way too much. So, hemoglobin is a protein inside the red cells. Makes the cells red, carries the oxygen. That should not be a surprise to anybody in this class right now, right? Okay, so normal red cells have a lifespan of approximately 120 days. And after 120 days, the red cell then gets taken apart and it goes in the body and the pieces get reused. So what happens when the red cells die? The hemolysis, the breakup or lysis of the red cells, 90% of the lysis is extravascular, occurring in macrophages. 10% occurs intravascularly. So, excretion of normal bilirubin. My button. I'm going to see if I can get a little bit. So this should look kind of like a graph you've seen in hematology, right? With the breakdown. Normally, conjugated bilirubin is excreted in the bile, which is stored in the gallbladder. From the gallbladder, it goes to the small intestines. From the small intestine, then bilirubin turns to urobilinogen. This is probably new. You probably have not heard that before, right? About the bilirubin turning to urobilinogen? Okay, good. Now I know where we're picking up from heme. So this is the new part. This is where we're going to start measuring urobilinogen from. Oh, it worked. Okay, so there's pictures similar to this in your manuals. Learn those pictures. Those pictures are going to help you. You need to know those pictures for quizzes, for exams. Okay? This is a normal cycle, what's going on. So, heme degradation, unconjugated bilirubin goes into the liver, becomes conjugated, goes into the intestine. In the intestine, we make urobilinogen. 20% of the urobilinogen gets reabsorbed, and then some of it then ends up in the kidney. That is why urobilinogen is never 0. We can say less than 0.02, but we never know if it's how much less, and we never say negative for urobilinogen because there should always be some circulating in the body. When it is less than 0.2, then we know we have something else going on, but we only know it as far as less than 0.2. So this is normal. This is normally how everything's going to work. Normally the bilirubin goes into the intestine to urobilinogen. Bilirubin does not spill over into the bloodstream. It does not go to the kidney. It does not go through the kidney. Yeah.
So you said that it was stored in the gallbladder. What happens in somebody who has their gallbladder removed?
It just goes right into the intestine.
Okay.
Yep, right into the intestine. Good question. So with jaundice is excess bilirubin. So it's bilirubin has that bright yellow color. Remember you guys learned about icteric specimens when you're doing BLS? It's that yellow, orangish, weird kind of color. That's what we're looking for. And because of that, when you're dealing with somebody who is not, for whatever reason, dealing with their bilirubin well, they turn jaundice. They turn that yellow color. The eyeballs are the first to start turning yellow, and then they get throughout their skin. So it's really important for us to test for urinary bilirubin and urobilinogen to detect early liver disease. And we can usually catch it before people really start turning jaundice. We can start catching it. Looking at the bilirubin and urobilinogen in the urine is used to tell us what type of jaundice we're looking at. So, jaundice classification, we have prehepatic, pre-liver, okay? That's usually going to be our hemolytic. We have hepatic, which is something happening in the liver to cause the problems. And then we have post-hepatic, which is obstructive. It's happening after the liver. So those are the 3 different classifications. So hemolytic, prehepatic, something's going on in the body to create increased red cell destruction. So your red cells are being destroyed. Oftentimes when we get into transfusion reactions, that's going to be part of it. It can be burns, different things. But what's happening is before the liver, you have all this excess red cell destruction, and the liver's trying to play catch up because it's responsible for cleaning that all out. This is caused by autoimmune hemolytic anemia, transfusions, or hemolytic disease of the fetus and newborn, which we'll talk a lot of detail about in blood bank. So prehepatic, this is what the diagram looks like. The heme breakdown is really high. Because of that, we have a lot of unconjugated bilirubin. If the liver's working well, it's able to conjugate it and keep up with it. And if it's able to keep up with it, it all ends up in the intestine and it all becomes urobilinogen. Here's what happens though. There's so much urobilinogen, 20% gets reabsorbed, so all of a sudden it wraps around here to the kidney and we have urobilinogen elevated in the kidney. The liver's working, it's able to conjugate all the excess red cells, but there's a lot more urobilinogen. So bilirubin will be negative, urobilinogen will be elevated. Prehepatic disease.
Is when you talk about the conjugated bilirubin being increased, is that just in the whole body itself, or like the urine? Because like we're learning that in the blood, you don't really see an increase of it just because the liver takes care of it.
Correct. So it goes right from the conjugated bilirubin, goes right from the liver to the intestines. So we're not going to see it in the bloodstream.
Okay.
If the liver is working well and everything seems like it should be, the liver is able to take that all and send it right into the intestines. So it's the urobilinogen that we see in the kidney and it goes through the bloodstream.
But like these increases, that's all in the body itself.
So the heme breakdown is what we see in the cells. So we're likely to see, our plasma is likely to be red because we have the heme breakdown in the bloodstream. Past that point, this is all happening in the liver and this is all happening in the intestine. Most of it lands in the feces. Most of the urobilinogen will land in the feces. That's what gives it its color. Lots of bilirubin gets handled by a functioning liver. Functioning livers can do a lot. They're as amazing as kidneys. Maybe not quite. I'm a little partial to kidneys. So lab tests, when you're looking at prehepatic jaundice, so you're dealing with the hemolysis, you're going to see increased urobilinogen in the urine, no bilirubin in the urine. Serum is going to be icteric, and that's going to be from the urobilinogen color. You might see increased serum total bilirubin, maybe, maybe not. Depends on how well the liver's working. Increased unconjugated indirect bilirubin, maybe, maybe not. In the stools, increased urobilinogen. We're never really going to test the stool for it, but it's going to be increased urobilinogen because the liver is working so well. Now, hepatic jaundice. Something is up in the liver. The liver is no longer functioning well. Because of that, it doesn't have the ability to conjugate the bilirubin as well. And so because of that, we're going to have, I'll show you the picture on the next slide, caused by hepatitis. Hepatitis is any inflammation of the liver. When we think hepatitis, we think of the virus, A, B, C, and D, and E. There's the E now, which you have to have C to have E. No, B and E. Is it B and E? I don't remember.
I believe it is C.
Is it C and E? C and E? It's been a while since I've looked through the hepatitises. So, but anyway, when people think hepatitis, they think the virus, but there are other things that can cause inflammation of the liver. Cirrhosis, drinking, Tylenol overdosing, lots of drugs. Every drug you take is cleared through the liver or the kidney. And so if you're on certain medications to stay alive, if they're cleared through the liver, they're going to be watching you really carefully to make sure they're not destroying your liver. So it's really important to always look at your meds and know whether they're cleared through the kidney or the liver and make sure that your physician is watching whichever one pretty carefully. So bilirubin is no longer effectively being conjugated if the liver is not working well. So here's the picture of what we're looking at. The normal amount of heme degradation, heme breakdown is going to happen constantly, right? Every 120 days, the cells are going to die and new cells are being born every day. The unconjugated bilirubin goes into the liver. The liver isn't working well, it's leaky. So we have some that gets into the intestine, the urobilinogen. Fecal urobilinogen is going to be normal to low. The urobilinogen is going to kind of squeeze back around. The urine urobilinogen is going to be normal or low because it's not breaking it down as well. But in this situation, because the conjugated bilirubin, or it's not all conjugating, it's leaking, and we're going to get bilirubin, unconjugated bilirubin, into the bloodstream. And because of that, our urine bilirubin is going to be elevated. So urobilinogen, low to normal. Urobilin, normal to low. That's going to be down here. conjugated bilirubin in the liver is going to be elevated and the kidney is going to be elevated. So lab tests we're going to do with urine results. Bilirubin is going to be one of the first signs often because urines get collected a lot. If you think of how easy it is to go to the doctor and collect a urine, and urine's going to tell you just so much what's going on. So a lot of times it's going to be one of the first signs that something is going on with the liver. Increased urobilinogen, sometimes we're going to see, most of the time we're just going to see the increased bilirubin. Serum results, increased total bilirubin, increased conjugated bilirubin. Stool results, decreased urobilinogen because the liver does not process and reabsorb the urobilinogen. So it's not processing it enough. So the urobilinogen that's going into the intestines there's not as much of it, and so it's not converting. You're going to end up with oftentimes less there. Obstructive or post-hepatic. After the liver, post-hepatic, obstructive, something's blocking it. Okay? Blockage of the bile duct or the biliary tree. This can be gallstones. This can be tumors. Pancreatitis can cause this. Bilirubin gets conjugated in the liver. The liver's working, but it can't go on through. It can't get to the intestine. It can't work its way back to the next step. So because of that, buildup is going to occur in the liver, and it's just going to kind of back up into the bloodstream. So, normal heme degradation, unconjugated bilirubin, the liver's working, but nothing's happening here. It's stopping. So because of that, we got all this conjugated bilirubin going to the blood, and the kidney's like, whoa, I'm trying to keep up here. Because the kidney's trying to do what normally is going to be done at this point, through the intestines. So because of the obstruction, urobilinogen is going to go way down because we're not getting any of the urobilinogen down into the feces. It's not going through. It's stopping. So you're going to get real pale stool. Somebody's like a clayish color stool because there's no color from the urobilin in the stool because nothing's going through. All this extra conjugated bilirubin is going to the blood, and the kidney's like, whoa, trying to keep up, and it's flushing out all this bilirubin. So the bilirubin is going to be elevated in this situation. Lab tests, urine results, decreased urobilinogen because of the blockage. We're not getting the urobilinogen into the intestines, and so therefore it's not reabsorbing. Bilirubin in the urine because of the overflow. Increased total bilirubin, increased conjugated or direct bilirubin just because it has no place to go, right? So it backs back up into the bloodstream. Stool results get that gray color because we don't get the color from the urobilin. Neonatal jaundice, slightly different. This is more just FYI. We'll talk more about this in blood bank. Increased conjugated bilirubin. So what happens when babies are in mom's liver is taking care of them, right? All the excess bilirubin is going back through the placenta, and mom is cleaning all that out. As soon as they're born, oftentimes their livers are not functioning. It takes a bit of time for their livers to start functioning. That's why so many babies end up a little jaundice early on in life. Most of the time, little jaundice, give them some sun, they're going to be okay. Most of the time, it's fine. Sometimes they have to undergo treatments when they're born if they have too much because it can become toxic to their brains. So we want to make sure that these levels are not getting too high so we don't have, it's called kernicterus, which are these plaques then that happen on the brain if their bilirubin levels get too high. If we had a bilirubin of 20 milligrams per deciliter in a baby, we start doing exchange transfusions, and what that is literally they take 1 milliliter of blood out and they put 1 milliliter of blood in, and they take 1 out and put 1 in. So it's called an exchange. We'll talk a lot more about that in blood bank. Most of the time, these babies are treated with Billy blankets, Billy lights, and it's just UV. It's a lot of UV, and the UV helps break down that bilirubin until their livers are functioning better. Reagent strips for bilirubin. The principle, you got a bilirubin that's going to combine with a diazo salt. It's going to happen in an acid environment and create this azobilirubin. It's a colored compound. So the specificity for this is very specific for bilirubin, But when you're dealing with any highly pigmented urines, it's going to turn that pad. So the pad starts as this really, really light color. So anything that might be a darker color, a dark yellow, a red, etc., is going to make that color look more colored. So we got to be kind of careful that we don't mistake a pigment for a color change. You're going to look at sensitivity. Multi-sticks, 0.4 to 0.8 milligrams per deciliter. Chem strips, 0.5 milligrams per deciliter. But then we got the Ictotest tablet. I'll talk about that in a few slides. 0.5 to 1 milligrams per deciliter. So when we're dealing with those, it's a lot more sensitive. So we'll talk about why that's important in a few slides. So other interferences, reagent strips are difficult to read. Because of all these other positives, we want to verify it truly is there, and that's when we're going to do our Ictotest. Because if we have a little bit more of a pink urine or a dark yellow urine that stains the pad, we're going to call it positive. Is it really positive? We want to make sure before we report it out that it truly is positive. False positives also can occur with certain drugs causing atypical colors of urine. Indoles can be formed due to overgrowth of some bacteria. False negative, exposure to light, especially UV light. That's why we treat babies with UV lights. But exposure to light is going to cause that bilirubin to be dropped. A decrease in conjugated bilirubin is converted to free bilirubin in vitro. So we're not going to see it. Ascorbic acid, there we are again. Another ascorbic acid, false negatives. We got to really watch for that. And then any sort of elevated nitrite concentration may decrease the sensitivity of the pad. Remember, it's always important to look at those physical characteristics, and if you remember, yellow foam is indicative of bilirubin. Now, for confirmatory tests, if bilirubin looks positive, we don't want to report it out unless it truly is positive, because it's going to send the doctors down this whole path of lots of testing on this patient. So that's where the Ictotest comes in. Again, most clinical facilities do not do the actual confirmatory tests anymore. You need to know this more for boards and understanding that it is out there than you do for actually doing in the real world. Some places do still do it though. So anybody that we suspect in our lab of being a positive bilirubin or urobilinogen, we must do an Ictotest on. Its principle is the same as the same dialysis reaction. It's just a lot more sensitive. We get this tablet and this special pad. We add 10 drops of urine onto the mat. We put the pad on, and then we end up putting a drop of water over the tablet till it runs off, and we look for a color change. So we're gonna add 1 drop of water at a time until it falls off, and then you're gonna see any positive color any positive is gonna be blue. Any blue color is considered a positive. Sometimes you have to take the tablet and like push it over a little bit with your forceps to see the blue color underneath the tablet, and that's okay. So sensitivity of Ictotest is very sensitive to bilirubin. It detects as little as 0.05 milligrams per deciliter. So as I said, it's going to detect the smallest amount. It's the most sensitive of the bilirubin tests that we have. Large amounts of ascorbic acid are going to suppress this test, and certain vivid pigmented drugs could affect it also. So now, let's talk urobilinogen. Approximately 20% of the urobilinogen that goes in the GI system is reabsorbed. Like I talked about a few slides ago, about 20% gets reabsorbed in the bloodstream, and then the kidney is what it goes through the kidney and gets excreted in the urine. This is why the normal urine is 0.2 milligrams per deciliter. There should never be a negative. There is no negative on the strips because there is no negative result on the strips. There should never be reported out a negative result. The other 80% of the urobilinogen then ends up in the intestines, and it turns to urobilin, which turns into the color of the feces, makes the color of the feces. So bilirubin gets converted to biliveridin, urobilinogen gets converted to urobilin. Reagent strips do not detect the urobilin, so it's really important to test these fresh urines before they have a chance to be exposed to light. The urobilinogen, the principle is the Ehrlich's aldehyde. It will react with both urobilinogen and the porphyrins. So it's really important to know that when you're doing these tests, that it could end up being porphobilinogen also. We're not going to see that very often in the urines. That's the multi-sticks. The chem strips, the principle is the diazoam reacts only with the urobilinogen in an acid media. So that's what we're going to see on the chem strips. We use the multi-sticks in our lab, but you need to understand every time you're out there, I always keep saying, read your product inserts, and this is why. Make sure to read the product inserts and know what you're testing for. Specificity and sensitivity, the multi-sticks is 0.2, chem strips is 0.4. If it's ever a different color left of the 0.2, it's less than 0.2. We never say negative. It'll be less than 0.2. Chem strips 0.4 is the lowest that it'll detect. False positive, sometimes you can get an intermediate substance, methyl-dopa, another med that can affect it. Highly pigmented urines and their metabolites sometimes can affect the color change. And multi-sticks, the warmer it gets, the more reactivity is increased. So we always test at room temperature. We don't want to test them in really, really warm areas. False negatives, any urobilinogen exposed to light, it's going to go away. So we want to make sure we do these right away. Formalin preservative, like I've said, certain preservatives are going to affect things. Diazo reactions are affected by ascorbic acid. So you get a false negative again with ascorbic acid. Porphobilinogen detection is unreliable. If you're looking for the porphobilinogen, a truly negative urobilinogen can only be verified on a fresh specimen, and we can't verify it with a dipstick because we cannot verify anything less than 0.2 on the dipsticks. Now, porphobilinogen is an intermediate compound formed in the synthesis of heme. It's a porphyrin precursor. You guys got this all in hematology. I'm not going to go back and review it all. If you need to, feel free to look at these next couple slides and review the procedure of porphyrin, heme synthesis, including porphyrin. Watson-Schwartz test for urobilinogen and porphobilinogen, that's confirmatory testing. I'm not going to spend a lot of time talking about it, but know that Watson-Schwartz is for confirmatory testing. Here are a chart looking at the Watson-Schwartz results, what we're looking at with different reactions. Here are your objectives for bilirubin, more objectives for bilirubin, your key terms for bilirubin. Here's a case study. We have a 45-year-old male came into his doctor after spending a second sleepless night with excruciating lower abdominal pain. The pain seemed to come in waves and was unrelieved by aspirin, Tylenol, and a 6-pack of beer. Lying or standing in any position, he had not experienced any similar pain before. So the macroscopic urinalysis, the color was a dark yellow, it was cloudy. Specific gravity was 1.015, pH of 6. Protein negative, glucose negative, ketones negative, bilirubin negative, blood 3+, urobilinogen negative. Do we ever have a negative urobilinogen? Nope, that's a mistake. Nitrite negative, leukocyte esterase negative. So, what's going on with this person? Whoops, I hit the wrong button. There we go. We did a microscopic urinalysis, white cells 2 to 5. Red cells greater than 100 per high power field, and no casts. Which of the likely is a likely interpretation for these results? Hematuria, hemoglobinuria, or myoglobinuria? We saw actual red cells in the microscopic, so it's probably going to be hematuria. What information on the urinalysis did you use to determine your results? Again, on the microscopic, we saw red cells. How the physical conditions in the urine, the pH and specific gravity are compatible with intact cells. So let's go back. Specific gravity, isothenuric to a little hypersynthenic, which is going to keep those red cells intact and not hemolyze. And the pH of 6, slightly acidic, is going to help keep those red cells intact. Another case study, 58-year-old male is seen in the emergency room complaining of intermittent severe pain that radiates from his right side of his abdomen and groin area. He has frequent need to urinate with little or no urine. Other complaints include a cold that he has been self-treating with over-the-counter medications and vitamin supplements for more than a week. Physical exam of urine, pink and slightly cloudy. Specific gravity greater than 1.030, pH of 5.5, trace of protein, nitrites were positive. Rest of the chemical exam was negative or normal. Microscopic exam, 10 to 25 red cells, 2 to 5 are normal, 5 to 10 white cells, few bacteria, and some calcium oxalate crystals. What are the abnormal discrepant urinalysis findings? So when we look at this, We don't expect to see red cells of that high amount. We don't expect white cells or bacteria in a clean catch urinalysis. We have a trace of protein and nitrites are positive, and the specific gravity is hypersthenuric. So all that's going on. Based on this information provided, which of the following is most probably the case of the patient's condition? Calculi, UTI, or acute glomerulonephritis? Based on the bacteria and the white cells, we're going to go with a UTI. State at least 3 factors that could lead to the development of the patient's condition. Dehydration can cause it. Specific gravity is really, really high. That could cause it.